Can I have my slides? Great. Okay, so good morning, everyone. So first of all, I'd like to thank the organizing committee for this kind invitation to talk in this session. So I'll be talking about management of presbyopic inlay associated complications. These are my financial disclosures. So many of you will be familiar a few years back with the camera inlay that was used for presbyopic correction. Essentially, it's a pinhole device that basically improves the depth of focusing by allowing you to focus through this small aperture. The distance vision was minimally affected, and the idea was to basically place this under either a flap or a pocket, and the idea is to basically increase the depth of focus through this small aperture. However, over the years, we all became familiar with some of the complications. Certainly in the earlier prototypes, there were minor complications, of course, related to decentration or loss of contrast sensitivity and glare inhalers. You can see this thinning on the ocular surface underneath the epithelial flap on a patient who had it done probably about maybe 15, 20 years ago. But over the years, we just started seeing some major complications such as melts, hyperopic shifts, and a haze around the implant. And this is related to the cellular wound healing response. If you look at the cases that we did basically in Singapore, about 30% of our cases started developing haze, and unfortunately I inherited a lot of these cases into my clinic to try to help them, to try to get some improvement. Initially you will see that the visual acuity results improved after they had the inlay with respect to their near vision, but you can see that basically when you look at pre-explantation, there was a reduction in the near visual acuity, and this was an indication that the implant wasn't really working that well itself. And about 30% of our cases developed this haze formation. 3 of these cases were placed under LASIK flap, and we noticed that they basically occurred between 3 to 7 years after the initial implantation. 6 months afterwards, after removal, there was some improvement in the visual acuity and some reversal of basically the hyperopic shift. The 2 groups of patients that I came across were really patients who had these under a flap device or under basically a pocket insertion, as you can see on the left-hand side. So of course a flap insertion inlay is actually quite easy. We were put under about 150 micron flaps, so you'll see these are slightly thicker than the flaps obviously that we do standardly for LASIK, but these are quite easy to lift. Even 3 to 7 years down the line, they were all basically done with the femtosecond laser. The pocket ones also actually surprisingly were also quite easy to actually dissect out, even though these were done almost 7 years after they were initially implanted, and I've opened them up even 10 years. The imprint of the device there, and I'll talk about a little bit in more detail, and that's really what we're going to have to talk about to get this removal. So this is an example of somebody basically pre-room explantation. You can see obviously the haze formation there still basically post, and you'll see some improvement with respect to the change on the tomography on the surface following improvement. Now if you take that inlay and you send it to the lab, this is basically what it looks like. So you can see under H&E staining, you see this luminescence basically affect itself. And then if you look at this in a little bit more detail across the surface of this implant, you'll see this fibrous acellular mesh across the surface. And actually what this is it's an acellular fibrotic reaction on the surface of the inlay itself. And what happens is that when you get this collagen reaction on the surface, it basically prevents the fluid going into the anterior lamellar cap, and that's why you get that flattening in the flap or the cap stroma and secondary changes on the epithelial surface. And interestingly, this mesh, this PVDF that was used on the camera implant, actually is used for hernia vascular repairs as well, and actually you get the similar kind of response with the hernias itself. But of course when you have a hernia repair, it's not such a big issue when you get this fibrovascular response compared to basically what you see inside the eye. So often what happened was you get situations like this where you basically get this haze left over. Patients have a reduction in their contrast sensitivity, and you can still have some residual basically hyperopic shift, and you can see this on densitometry, also basically on OCT, and likewise you see the same effect on tomography. So many these patients were then sent to me to try to sort out, to try to see how we can basically help them in this situation. So what we did was that we basically came up with this idea about trying to basically do this as a 2-step procedure. So what I'll show you in a minute is that you'll see the haze both on the cap and basically also on the bed. So in the stage 1 of the procedure, obviously we remove the explant itself. Stage 2 of the procedure, you go back, and what we do is we laser the actual underside of the flap itself. And typically once you can lift basically the LASIK flap, I put this on a evisceration spoon to basically balance this. You need to switch off the tracker off the laser itself, so you can see it on the spoon. You need to lie this down quite flat, and then I use a basically PTK module and then mitomycin C on the surface to help basically get the haze. And then basically after vigorous washing, you basically put the flap basically back down for a month before you basically tackle the bed. This is basically what it will look like after the first stage of the procedure. And normally, basically, once you leave it and it settles down, you can see at 5 months post-operatively, you get a reduction in the initial swelling, and you can get some improvement in the visual acuity. You then go back, basically, a few months later, and then what we do is you go back and lift the same flap up, and this time we laser the bed. And the options are here, depending on not whether there's a cataract, you either use basically a PTK module, or you basically do an excimer ablation, as you would do basically for LASIK itself. But again, the difference over here is that once you do the ablation on the bed itself, you then also have to do, we also use mitomycin C on the surface as well to help basically reduce the wound healing. So once you do the excimer ablation, then we put mitomycin C, again, exactly the same way as you do for standard surface ablation in your cases, and then this is basically washed, and then the flap basically replaced on the surface. And this is kind of improvements that you can get. It will not go completely, but you get quite a reasonable improvement, and likewise some improvement with respect to the visual acuity results as well. And you can see on the OCT you get some kind of improvement as well. This is kind of some of the cases that we had initially looking pre-op. This is basically 6 months post improvement in vision after the first ablation on the cap, and this is basically after the bed ablation as well. If you want to use a nomogram, this is something we published basically in JRS last year. It shows you whether we choose whether to do PTK or basically PRK, and you'll see an improvement with respect to the spherical equivalent, of course, after the laser ablations, and also improvement on densitometry using the pentacam after you've done the ablation treatments itself. The main basically factor with respect to how much haze you remove will be dependent on the severity of the haze following the explant removal. So I do counsel the patients very closely with this, because this is going to basically determine the outcome from how much haze we can remove itself, because of course there's a limitation with respect to how much stromal tissue you can remove. So the small aperture corneal inlay causes acellular extracellular matrix reaction in the corneal stroma following implant removal. This has an effect on contrast sensitivity and aberration reduction. Sequential laser ablation, either PTK or PRK, to the bed and the flap can basically reduce this. I do this as sequential procedures to basically try to refine the refractive outcome, and the variation is dependent on the degree of the host explant haze. Some of the cases do have very severe haze, and of course you have to counsel the patients. You're not going to be able to get rid of it completely, but you will get significant improvements. Thank you for your attention.
Thank you, Dr. George. Just a question. The percentage of people developing this haze is what, in your 8%?
So they were implanted like when I first went to Singapore, so like 2007. I'm quite happy that I hardly did any of them. I tell you, I think that 60 were implanted in Singapore, mostly under trials, and I would say probably about 30 to 40% get haze, and I've taken out about 30%. So I've taken out at least about 25, and that series is about 12. I mean, bearing in mind in Japan they put 10,000 in. So, yeah.
So one of the things which I was thinking when you're presenting is if they have a higher threshold of having more ocular surface related inflammation driven by the TGF or TNF alpha pathways, they are the ones who would behave completely different when you put anything in the cornea. It's like doing a PRK.
Yeah, so I think you're correct. I mean, I think that there would be a difference in whether they would get haze. Not with this inlay, but with raindrop inlay, we did study cytokine profiles and stuff as well, because they also had stromal issues and stuff. So there was a whole series of cases, I think, done in Mexico, and they took tear samples and they sent them to us, and we did analyze the tear samples as well, and we did see differential responses with the ones that had the inlay in versus basically not the inlays. But you would expect a difference. But actually, we are seeing this now. I think, honestly, if I would advise you, if you have patients with these inlays in, I'd take them out, because they all have some sort of haze response, and I would remove them, definitely.
Yeah. Here. So in fact, I have a series of 3 patients that we did 7 years back. You're right. One patient had a severe haze, so we had to lift and remove the inlay.
Yeah.
The second patient had a cataract.
Yeah.
So we just did away with the cataract, but there was just cellular infiltration all around the inlay.
Yeah.
But she's doing well. She's one of my OR sisters.
Yeah.
So I was just asking, once you lift the flap, how much is the target ablation that you're doing on the undersurface of the flap?
So I measure it on the OCT. So what I do is I measure it on the OCT. Remember, the flaps were basically created with about 150. So I do basically between about 40 to 50 microns, and then I actually use the OCT to basically on about 5.5 millimeters when I do the ablation on the flap itself. And you get some quite decent improvement on that. So what I do is when I see the inlays in, if there's no hyperopic shift and they have a cataract, then I do the same. So I do cataract surgery on them and I aim for a myopic outcome like 0.5, 0.75 so they can start to try to use the inlay. If the patients have a hyperopic shift pre-op, then I tell them, I either pre-treat them with steroids or I tell them to remove the inlay first, and then I tackle the problem by then treating the haze, and then I do the cataract surgery after that.
Now the question is for the third patient where I did it under Zimmer, I made it a pocket, and then now there is a haze.
Yeah.
So what do? I can't lift.
No, so what I would do is that I would use the Circle software from Zeiss, and then basically make that pocket into a flap, and then lift the flap up. That's what I would do.
Okay, so the parameters have to be taken from that.
Yeah, so you can take that, but you see that your pocket was probably, your pocket was also probably about 150 as well, right? Yeah, correct. So you can do OCT to give you some sort of idea, and the Circle software allows you to have a 10 micron side above and below. So I'd aim for basically 150, and you're going to get very, very close to that level of the interface. So I'd make it into a flap, and then you can start with the whole haze, and make it into flap, and then start with the whole haze induction from there.
Thank you. Thank you.